Hi everyone, this is Professor Nicholson lecturing on intraoperative nursing. Please review Unit 9, Module 2 subcompetencies on your own. Two types of surgeries include elective surgery and emergency surgery. Elective surgery is typically scheduled and has a set date. Emergency surgery is something that is unexpected. There are three zones in the operating room. You have the unrestricted, the semi-restricted, and the restricted. Surgical attire should be worn in semi-restricted and restricted areas of the surgery department, and this includes a head cover, masks, scrub suit, warm-up jacket, and shoes. You should not wear any outside clothing into these areas. Within the operating room, there is positive air pressure, there's lighting. I know when I have certain procedures such as cesarean sections, we like to make the lighting nice and dim and soothing for the patient, but make sure that the surgeon can see what they're doing, of course. There's electrical safeguards within the area, emergency backups, temperature and humidity controls. It's imperative for members to understand fire safety as well. There's typically drills every year on how to do this. Intraoperative team members include scrubbed sterile team members and clean members. The scrubbed sterile team members include the surgeon, surgical assistant, and the scrub nurse or scrub technician. Some facilities do train their nurses to scrub in if there is no technician available. Clean team members, so the ones that do not need to be scrubbed in sterilely, but need to make sure they wear sterile attire, as mentioned earlier, because this is a restricted area, include team members such as the anesthesiologist, the circulating nurse, as well as other technicians. The scrub nurse or scrub technician role includes the following responsibilities. So preparing the sterile equipment and supplies, assisting the surgeon during the surgery, hand instruments to the surgeon during the procedure, and assisting counting instruments and sponges with the circulating RN. It's imperative for you to understand the roles of the circulating nurse. One of the most important ones is to know that this nurse coordinates the surgical team and manages patient care activities in the OR. You're basically the patient's person, so you are in charge of that room. The nurse needs to identify the patient prior to being brought to the OR suite. I typically do this the second I walk into the room and I look at the time, I state the time, and I identify the patient. You need to verify with the patient the procedure to be performed and operative site. You need to ensure the OR site is marked with a skin marker. This would be the left or right, of course, as applicable. Sometimes there is no site marked, such as, during a C-section, but if you are doing anything that has a left or right significance, it is imperative this is marked to ensure patient safety. You need to assess the patient data from the chart and include lab work, medical conditions or disabilities, prosthesis, allergies, operative permits, advanced directives, and any other pertinent data. You need to know this patient. You need to make sure that there are also consents signed for this procedure. Please note, if you do not understand any of this lingo, please take a second and look it up. Continuing on with the circulating nurse role, preoperative care consists of staying with sedated patients, conversing calmly with them, making them comfortable, reinforcing the patient's and family's trust, and checking on IVs, administering preoperative medications such as pain medications, antibiotics, and steroids. The circulating nurse should be standing by when the anesthesiologist begins induction of anesthesia to assist and ensure patient safety. Sometimes the circulating nurse even provides cricoid pressure for the anesthesiologist. The circulating nurse shall position the patient to avoid any pressure points and maintain good body alignment. This prevents nerve and muscle damage. So just to reiterate, for a patient having surgery undergoing regional anesthesia, positioning for patient safety and comfort is key. Continuing on, While circulating, the nurse must be able to operate all equipment necessary for the surgery, such as tourniquets, cautery, suctions, air equipment. The circulator is also responsible for sponge, needle, and instrument count as described in the count procedure. With the scrub nurse and/or technician, they must concurrently verify the name, concentration, and expiration date of medications and fluids passed to the sterile field. The surgical prep may be done by circulating nurse or surgeon, and the circulator is able to anticipate needs of the scrub nurse and/or technician and is prepared with extra sutures, sponges, instruments that might be needed as well. The circulating nurse clearly communicates with the surgeon and scrub regarding specimen preparation as applicable, such as during a tubal ligation, the circulating nurse must label whether it's the right or the left tube. At times of temporary and permanent relief by another circulator, the nurse must provide a report of the progress of the procedure, patient information obtained during the preoperative assessment and interview, any special needs or requests of the operative team, and any other pertinent information deemed necessary. The circulating nurse is responsible for the intraoperative records and the accurate recording of surgical charges. And lastly, the circulating nurse is responsible for all visitors, guests, traffic, and official documentation in the OR suite. At close of surgery, the circulator should be close by the patient to keep them from injuring themselves on awakenings from anesthesia. Should also be available to assist anesthesia when extubating if necessary. The circulating nurse must accompany anesthesia with the patient to the PACU and give report. So the circulating nurse does have a very critical role. These are some diagnostic assessments that are typical for patients prior to having surgeries. I want to reiterate x-rays because a lot of the lap sponges that are utilized within the surgery are x-ray detectable. That being said, if there is ever a count that is off, this circulating nurse must tell the surgeon, and before the patient even leaves the OR, they need to have x-rays done to ensure that there are no lap sponges within the cavity. Checkpoint. What does the circulating nurse do if there is a discrepancy in a sponge count? The answer is recount. The nurse would then determine if there is a discrepancy, and if there is, then there needs to be an x-ray done to verify that there is nothing in the cavity. Please review this statement from the Joint Commission. The following are documentations the circulating nurse needs to do in order to fulfill the timeout. In order to eliminate patient errors, there needs to be a mandatory system of double checks. All members of the surgical team must play a role in patient identification. The correct patient and the correct site needs to be determined, and the MD signs the incision site. If anybody in the care team does not follow these rules, it is important for the circulating nurse to step up and go up the chain of commands to maintain patient safety. I'm going to reiterate that this is an important slide and that you must understand site errors in the OR. So, this would include lack of intraoperative site verification, when multiple procedures are being performed by the same provider. There's ineffective handoff communication or briefing process. There's primary documentation not being used to verify the patient, procedure, site, and side. The site mark is removed during prep or covered by surgical draping. There's distractions and rushing during timeout. The timeout process occurs before all staff are ready or before prep and drape occurs, and timeout performed without full participation. These are all errors that could, are all surgical site errors in the OR. It's important to know the anesthesiologist's role in the OR. So they are the ones that administer anesthesia, whether it's local or general. They are the ones who monitor the patient vital signs, their level of oxygenation as well. They monitor patient level of consciousness. They are the ones to administer IV fluids and blood products. Typically, they are the first to diagnose and treat medical problems or complications that may arise before, during, and after surgery. Surgical scrubbing is not necessary for the anesthesiologist. However, it is for the scrub assistant, scrub nurse, and surgeon, as I mentioned earlier in this PowerPoint. You will need to know that. Before surgery, the anesthesiologist evaluates the patient to develop an anesthesia plan, taking into consideration the patient's medical history and physical condition. During surgery, anesthesiologists use advanced technology to monitor the body's functions and determine how best to regulate and treat the body's vital organs while administering a personalized, delicate balance of anesthetic medications. In some hospitals, nurse anesthetists may assist the anesthesiologist with the monitoring. However, anesthesiologists are responsible for interpreting the monitoring and making medical judgments about the patient's responses and necessary treatment. After surgery, anesthesiologists reverse the effects of the anesthetic medications and return the patient to consciousness. They keep the patient in a comfortable state during recovery and are involved in providing critical care medicine in the intensive care unit. Please review this slide on surgical positions. I will say you do need to know these positions, especially Trendelenburg and the lithotomy position. So, what kind of surgeries occur during these different positions? Skin preparation includes using antimicrobials, removing hair at the site, as well as draping the patient. You need to know that prepping the skin reduces the amount of microorganisms. So after your timeouts, after your skin preparation, after the site is verified and the surgical team is ready to get going with the procedure, these are the ways the patient is monitored during the surgery. Sometimes blood gases are obtained, sometimes they are not. It really depends on the patient and how they are doing during the surgery. At the termination of surgery, dressing and drains are in place depending on what surgery it is, of course. Documentation needs to be completed. There needs to be a transfer report to the PACU nurse from the circulating nurse, and the nurse should inform the family on how the patient is doing. Of course, keeping in mind that doctors are the ones that need to give the full information, but it is okay for the nurse to tell the family that the patient is doing okay and that they are in the PACU. There are surgical daycares. The advantages are that they're cheaper, there's better anesthetics, it's a quicker recovery time for the patient, there's less time off and less infections. And disadvantages include little assessment time, fewer interventions, more readmissions, and little teaching times. Just something for you to, understand about surgical daycares, nothing that's pertinent for you to know at this moment, but just being familiar with it. And that is the end of this presentation.